Today's subject is a very controversial subject, and we have chosen this subject because it is controversial, and we want to have a clear idea about this type of management. The subject will be today or tonight, low back pain, and we have invited to our Saudi German Hospital webinar eminent speaker and eminent doctors. They are figures in this subject. I will just start with our Dr. Adil Siddiq Kamil. Dr. Adil is a pain management consultant, and he will give us definitely some ideas and some clearance about how the low back pain management or low back pain management will be. Also, we have Dr. Maan Gattan, is a known figure also in the anesthesia and pain management. And definitely Dr. Maan will enlighten us about the low back pain management. Dr. Adina Nabil Abbas is also a consultant in pain management and anesthesia. And it seems to be that I am the only surgeon in the group. So the discussion will be more hot. So we will talk about the view of the surgeon in management of back pain, and also the management before or after the surgery from our team today, our speakers. Now let's start with Dr. Adil Siddiq Kamal, sorry. Dr. Adil is a graduate from King Abdulaziz University and in Jeddah, Saudi Arabia, and he is currently member of the following prestigious organization: Anesthetic and Respiratory Equipment Standardization Committee and Saudi Drug Authority, SFDA. This is the regulatory organization of all whatever drugs and appliances in medicine and others. He's also member of the Scientific Committee of Anesthesiology in the Saudi Commission of Health Specialties, and Deputy Chairman of the Scientific Committee for the Saudi Board of Anesthesia and the Saudi Commission for Health Specialty. Dr. Adil is currently is the director of pre-operative services in King Faisal Specialist Hospital and Research Center in Jeddah, Saudi Arabia. Dr. Adil will give us his talk about the diagnostic dilemma of low back pain. Just for the logistic point, we will finish all the speakers first, and then we will address them the questions that are coming from the participants and also from the chairman. So let's start with Dr. Adil. Please, Dr. Adil. Diagnostic dilemma of low back pain. Tafadhal, Doctor.
Thank you, Mr. Chairman, for the introduction. Assalamu alaikum and good evening, everyone. And I would like to thank the Saudi German Hospital staff for the invitation, to special Dr. Adina and Dr. Yasser. It is my pleasure to be here with you tonight. And the topic of this webinar is low back pain. And we chose webinar low back pain, a common problem, because it is a common problem. It is the third most common cause of chronic disability in the world, and especially in the United States. 60 to 80% of all of us would have experienced low back pain at one point of our life. Luckily, the majority get better within 4 to 6 weeks. In the US, the prevalence of low back pain is about 56%, with amongst those 56%, the ones who were diagnosed with a disc prolapse or a disc rupture, the 90% of those have the disc prolapse or disc rupture at L4-5 and L5-S1. So the most common location is L5-S1, followed by L4-5. As I said earlier, most of the patients would recover. 90% would recover without surgery, and about 50% of them would recover at least within the first 4 to 6 weeks. There are many causes of low back pain. Luckily, the majority are benign. But of course, when we evaluate the patient, we have to dig like a very thorough history and clinical examination, and that would certainly make the big bulk of the diagnosis. Since our medical school days, we were told to, when we evaluate pain, of course, we have to check about the location and duration. The location, of course, that would help us evaluate if the pain is localized to the low back, or if it radiates to the thigh or the leg or the foot, because those would help us differentiate which would be the causative, the cause of the low back pain. Of course, the duration will help us discriminate or differentiate between the acute versus chronic pain. Amongst the characteristics of pain or the details of pain, we have to look at the palliative or relieving factors, or provocative or aggravating factors. So what makes the pain worse and what makes the pain better? The quality of pain, what does it feel like? For example, if the pain feels like burning, electrical, pins and needles, that indicates there is a nerve involved. If it's sharp stabbing, this could be acute, like a tissue injury or muscle pain. If it's dull, achy, vague pain, that might point to a disc prolapse. So the nature of the pain is very helpful to as a clue in the diagnosis. Radiation is also a problem. We have radicular pain versus referred pain. And as I mentioned earlier, the most common site for the disc prolapse is L5-S1 followed by L4-5. And because of that, if the pain reaches the foot, then that's a definite radiculopathy, because the referred pain will not pass the middle part of the leg, so posteriorly. If the pain is mostly anteriorly, that's a clue that this is a disc prolapse, if the pain, most likely. If the pain is posteriorly, most likely it is a referred pain from either a sacroiliac or facet joint or a muscle. Severity is also important to evaluate the degree of effect on the patient activities of daily living because of this pain. And of course, past medical history is also important because if a patient is a diabetic and complaining of burning sensation of both feet, that can point into a diabetic neuropathy, or rather than a possibility of a radiculopathy. But of course, the nature of the pain, if the pain or the numbness feels like a stock and glove, then that points to diabetes rather than radiculopathy. Hypothyroidism can also cause a neuropathic pain. Psychosocial, the nature of the job of the patient can sometimes clue into a disc prolapse or not. I have seen many patients who are bodybuilders and they come to me with facet joint disease because of the nature of the exercises they do, and they squat with heavy weights, and that can certainly cause a problem. So asking these questions can certainly be helpful as a clue to the potential diagnosis. Previous treatment is also important to check if the patient have had physical therapy or acupuncture or tried some medications, whether topical or systemic, in order to treat their pain. After the thorough history, of course, we have to do a thorough medical evaluation or an exam of the patient. And it starts with the patient walking into the clinic. So we have to check the gait. If we have a patient with a waddling gait, that sometimes indicates obesity, and that can point into a disc problem. Shuffling gait might point into a drop in the foot, and that can point into a compression on the sciatic nerve. We have to check the trunk mobility. If the patient has more pain on bending forward, that points to a disc problem. If the patient has more pain on extension backward, that points to a facet joint disease. Palpating or inspecting the back is useful. Of course, we might check for tenderness in the lower back. Generally speaking, the disc prolapse per se does not cause localized tenderness, while local issues, local diseases like a muscle or a facet joint or a sacroiliac, they can cause localized tenderness. Checking the straight leg raise test is also a useful thing to decide or to determine the diagnosis, and we'll talk about that in a few minutes. Provocative testing, I mentioned about bending forward and extension backward. Also Faber test or the figure of 4 test, and I'll talk about that in a minute or two. So also checking the power and tone and the reflexes and sensation of the patient is important to determine whether this the cause of the pain is either central or peripheral. So testing the muscle tone is important, because if you have an increase in the tone, usually that points to an upper motor neuron lesion in the form of spasticity or rigidity, while a reduced tone will point more towards a peripheral or low motor neuron lesion in the sense of disc bulge pushing on the sciatic nerve. So it's important to test the tone, the reflexes, and the sensation. So therefore, these are the just a quick refresher of the tone or the reflexes. I'm sorry. Normal reflexes would be 2+. A diminished tone, a diminished reflex would be 1+ or 0, and that's common in lower motor neuron lesion like a disc prolapse, while an exaggerated reflex like 3+ or 4+ points to upper motor neuron lesions. Sensation, testing the sensation also important. So the physician has to be familiar with the dermatomes, the dermatomal supply. An example would be like a big toe would be L4, middle toe would be L5, and small toe is S1. So a reduction in the sensation in those areas would point to the potential level of the spine affected. Now to the causes. The most common cause of low back pain or mid back pain and upper back pain is muscle problem or a myofascial pain. And here the tenderness is located far from the midline. It is not paraspinal. It is more lateral where the muscles are. We have recently started seeing more patients with mid back and upper back pain, especially a young generation, and that's usually due to the cell phone use, if you call it cell phone syndrome, and that ends up with, and those patients end up with tenderness of the muscles around the scapula, especially on the lower edge of the scapula. So it's important to differentiate between the cause of the pain depending on the location of the tenderness. If the tenderness is far lateral from the midline, it cannot be a facet joint, for example, and cannot be a disc prolapse. It must be a muscle problem. While facet joint disease, which or degenerative changes in the spine, cause about 10% of the total causes of low back pain. Of course, we have to differentiate between facet joint versus facet joint as a source of pain versus the disc prolapse per se as a source of pain. And as I mentioned earlier, generally speaking, disc prolapse does not cause localized tenderness, while facet joint does. And as I mentioned in the clue, with back extension, if the pain is more on back extension, then the most likely cause is facet joint. Quite often, both conditions coexist, especially in elderly patients where they have generalized osteoarthritis, and those degenerative changes started to occur all over the body. So you might have a patient with sciatic, with a disc prolapse, with a facet joint disease and sacroiliac joint disease. You have to be very careful when you assess the patient by history and examination. So tenderness of the facet joint or the facet joint disease, the extension of the pain is usually paraspinal tenderness over the facet joints, and the pain radiates posteriorly and the lateral part of the thigh, and the pain gets worse on extension. While sacroiliac joint, the pain is lower than, so it is in the upper part of the buttocks, and if you feel the sacroiliac joint, you would feel most of the tenderness over the joint itself, and the pain would radiate posteriorly all the way down to the mid-leg. And to confirm the diagnosis, we can do the Faber test or the figure of 4 test with the affected leg bent at 90 degrees at the knee, and the opposite hip is fixed by the non-dominant hand of the examiner, and then the examiner would push on the knee of the affected leg down, and that would regenerate the pain. And that's a clue that this is a sacroiliac joint disease rather than a facet joint disease or a disc prolapse. So it is important to do these tests to differentiate about the etiology of the low back pain. Degenerative disc disease, not every low back pain is happening from degenerative disc disease. As I said, it could be facet joint disease, especially in young athletes who do certain exercises and lift heavy weights on their shoulders, and that can cause exacerbation of the facet joint developing. But here the slide shows you different stages of disc disease. The one on the left is a total normal one. The second one is the mild, and the third one is the moderate, and the fourth one is the severe disc joint. And this is an MRI that shows you the different stages in the same patient. The MRI on the right side, the L5-S1 with the disc prolapse, L4-5 with a dry disc, and the one above that is normal discs. So this is how the MRI looks like. And here, when we talk about disc prolapse or radiculopathy, as I mentioned earlier, if the pain reaches the toes or the foot, that's a definite radiculopathy, because the most common site involved is L5-S1 and L4-5. While L1-2, L2-3, and L3-4 are not that common, but if they do, they would present with pain in the thigh, mostly anteriorly. That's just the clue. It is not a must, but usually anterior pain is a radiculopathy, and the posterior pain is referred pain. Straight leg raise test is also a useful test to help you decide about the diagnosis. The straight leg raise test can either, in a normal patient with no pain, the patient can raise the leg up to 90 degrees with no problem, no pain. Patient with a pain problem could either present with low back pain or leg pain. If the patient present with a low back pain, that indicates mostly the disc prolapse is central rather than unilateral. What I mean, for example, here, the right side is raised about 35 degrees to 75 degrees. If the disc prolapse is on the right side, the patient would have pain in the leg at 35 to 75 degrees, while if the patient is going to have pain in the low back, that sometimes indicates that the disc bulge is central rather than to one side, either right side or left side. So, so with this test, you can either have a low back pain, and that gives you a clue about the direction of the disc bulge. But if you have pain, whether in the leg or low back at 35 degrees, this can indicate either acute spondylolisthesis, or if you have a low back pain at 35 degrees, it might indicate gluteal abscess or tumor in the buttocks, or sometimes maybe indicating a dural inflammation at 35 degrees. If you have pain in the leg at 35 to 75 degrees, that's usually indicate that there is a disc prolapse at L4-5 and L5-S1. If you have pain beyond 75 degrees with tightness in the hamstring muscle, usually that indicates a hip problem or sacroiliac joint problem rather than a radiculopathy. Other less common causes of low back pain includes osteoporosis. Osteoporosis per se does not cause pain, but if it's combined with arthritis, so the patient has osteoporosis and arthritis, then they would have pain. But osteoporosis alone per se does not cause low back pain. Spinal stenosis can cause also low back pain. One of the pathognomonic features of spinal stenosis is pain relief on bending forward. So you might get a patient who tells you, when I go shopping in the supermarket and I lean on the shopping cart, my pain gets better. So that's an indication that you have relieved the stenosis a bit and the pain is better. But when they walk more, they get claudication, and that's called neurogenic claudication, which is the clue for spinal stenosis. Other less common problems, spondylolisthesis, discogenic problem, traumatic fracture, congenital. Cancer is not very common, of course, and infectious is also not very common. Now, some red flags with history and examination. In history, if we have a patient mostly complaining of night pain with fever and weight loss and history of cancer, you have to think about neoplasm and think about spread of cancer to the spine. And here you have to do an MRI. If you have a patient complaining of fever and there is a history of IV drug use, that can point out to discitis or epidural infection. If you have a patient complaining of bowel and bladder dysfunction with weakness in the legs, that points out to Coda equina syndrome. If there is a history of fracture, that can lead to a diagnosis of compression fracture. So those are the red flags that you have to think about when you want to order MRI. How to diagnose low back pain? Mostly by history and physical examination, as we mentioned, because X-ray has no major role in the diagnosis. Usually in young and healthy patients with low back pain, the X-ray are not useful, usually not necessary, especially if the cause is a muscle or a ligament problem rather than an actual pathology on the spine. But you might want to do an X-ray if the patient is more than 50 years old and the symptoms don't improve in 6 weeks. And there are other findings that might worry you, like numbness or something like that. MRI is definitely indicated if the symptoms last more than 6 weeks with the radiculopathy or sciatica symptoms. So as I said, MRI is warranted if there's red flags, and I mentioned them earlier. If there is neurologic deficits or progressive neurologic signs, then you need to do an MRI. And if the pain persists beyond 6 weeks, you have to do an MRI. With this, my part of this evening presentation is done. Thank you very much for listening. I will stop sharing, and then I think Dr. Ma'an Qattan, my colleague, will proceed after me.
Thank you very much, Dr. Adil, for this really informative but jungle of information that I have already a lot of questions for you, so be prepared to that
Sure.
at the end of the session. Now, as you have said, we will proceed with Dr. Ma'an Qattan. Dr. Ma'an is a well-known figure in the anesthesia and pain management, and also known to me as a real colleague and a nice friend. Dr. Ma'an is born in Riyadh, in Saudi Arabia, and graduated from King Abdulaziz University in Jeddah. He got anesthesia training at University of Ottawa. And then he did 3 clinical fellowship, mashallah, in chronic pain, thoracic anesthesia, and regional anesthesia. And Dr. Ma'an is currently working in King Abdulaziz Medical City, National Guard in Saudi Arabia, in Jeddah, and also as a consultant anesthesia and pain management in the section of head and pain management services. Dr. Ma'an will give us his talk about conservative management of low back pain. Dr. Ma'an, welcome, please.
Thank you, Mr. Chairman, for your kind words and introduction. And thank you, Adil, for a great presentation of the history and physical and diagnosis of low back pain. So my focus will be simple and concentrated, as you said, Mr. Chairman, about the conservative therapies. So basically, I'm going to talk about the evidence-based non-interventional therapies in low back pain with different diagnoses. So I'll brief you with a little bit more of an introduction, and Ad had already actually told us most of it. So we know it's actually the most common, one of the most common reasons for attention, second only to respiratory illnesses. Nowadays, people are coming, والله فينا شر الوباء يفك عنا الغمة with corona and all sorts of respiratory symptoms, but it's actually the second most common reason where patients seek medical attention. So at any point of time in our life, we will get an episode most likely of low back pain. About 84% of adults would have it at some point. There is so many wide varieties of approaches to treatment. It's very highly influenced by the specialty, by the evidence, and by institutions and by nations. And you will read in literature all sorts of approaches to treatment in which nobody has a clear path to say, you know what, this is the right way. Honestly, practicing for so many years and talking to colleagues from different specialties, as Mr. Chairman was saying, you will see a lot of people are talking differently. So most episodes, the good news, most episodes are actually self-limited. Some actually suffer from recurrent or substantial impact on quality of life and go to chronic. So almost any structure in the back can cause this. Ligaments, muscles, blood vessels, annulus, nerves. After 70%, as Dr. Adel was saying, of muscles and muscle sprain, you would see intervertebral disc and facet is most commonly affected. 85% of those usually have clear localization, but most of them, they are called strain or sprains. There is no actual anatomical location or histopathology that you can say, you know what, they have an actual disc prolapse. Both men and women are equally affected, and usually the commonest onset is between 30 to 50 years. It's the leading cause of work disability, at least in the Western or developed countries, in less than 45 years. It's most expensive cause of work disability in terms of worker compensation. And there are multiple risk factors, usually with heavy lifting, twisting, vibration, obesity, poor conditioning, and so on and so forth. So the good news, 90% of it have excellent prognosis. They have actually mostly mechanical pain. In the acute phase, by the first week, 50% will be better. By 8 weeks, 90% almost will resolve. Less than 5% will actually progress to chronic pain. So that's actually very reassuring. Now let's talk about the bulk of the therapy. Now, for non-specific low back pain, which most of us would see at the beginning, unfortunately, there are few RCTs. The problem with these are actually generally poor quality evidence. But to come out of it, the conclusion in most of it, non-steroidal anti-inflammatory and muscle relaxant are actually good for symptomatic treatment. And usually, most of us actually would use them on a regular basis instead of as needed for the first 1 or 2 weeks at least. Now, there are some very limited utility in the studies for chiropractor or spinal manipulation. And I wouldn't recommend it, at least in the acute or even chronic ones, unless there is a clear outcome out of it, but the evidence is not strong. Usually, what we recommend in the acute setting is return back to normal activity as much as possible, but neither you do bed rest or exercise in the acute period. So the limiting factor is the pain. So if the patient comes in with an acute non-specific low back pain, you ask them to be as active as possible, but avoid bed rest because it can delay recovery by evidence, and avoid exercise at the beginning. So as I said, exercise is not useful, or physical therapy is not useful in the acute phase, but it's actually very useful in the chronic phase. Traction TENS are usually minimally effective or ineffective. I avoided talking about interventional or any surgical therapies. I'll leave that to the expert. Dr. Dina is going to talk to us about interventional, and we have Mr. Chairman, the surgeon, who's going to probably brief us about some evidence, or we can discuss that later on. So systematic reviews actually in acupuncture have shown some little benefit. Usually my recommendation, if they know a good place, they can try it, but I tell them probably won't benefit out of it. Massage therapy, there are some promising results from some of the studies, but again, the evidence is not out there to recommend it clearly. Now, when we go to herniated intervertebral disc, which is again a common diagnosis, we prefer, most of us actually, to do non-surgical treatment for at least a month to 6 weeks, as Dr. Adil had alluded to nicely in his presentation. The exceptions are the red flags. So when you see, for example, Kodak Wine syndrome or progressive neurological deficits, this is something that you have to just refer to your colleague in surgery. So the early treatment is the same as non-specific low back pain, but you may need to add a small little short courses of narcotic for pain control as needed. Again, bed rest is not useful in such diagnosis. Now, for spinal stenosis, usually the physiotherapy is very recommended to reduce the risk of falls, as evidenced by most of the studies. And usually we try and use simple analgesia and non-steroidals. Now we come to the common thing that we see in our chronic pain clinic. Chronic pain clinic, most of the patients actually would benefit from a multidisciplinary approach. Intensive exercise improves the function and usually reduces pain, but it's difficult to adhere to it with most of the patients, and that's the difficulty we find most of us with our patients. Antidepressant might help actually, especially commonly, most of them are actually depressed. Opioids, as been shown by a small RCT, that it might improve the mood. It has some better effect on pain than non-steroidal, but there is not strong evidence to actually start it as a first line. And it does not actually improve your patient activity. So functionally, it does not give them a head start, but mostly it does improve the pain scores and the mood. The only problem or the caveat to it is the significant side effects, and we understand there are so many: drowsiness, constipation, nausea, worry of addiction or psychological dependence, and so on and so forth. So most of these patients actually do benefit from a multidisciplinary pain center or a center of excellence, places where they deal with them, adding the physical and psychological factor, cognitive behavioral therapy, biofeedback, appropriate education, exercise, and occasionally we refer to the nerve blocks, and this we'll hear about it from Dr. Dina later on. So the first line therapy, usually we start with simple. So you start with acetaminophen or steroid, and then you can add some adjunctive therapy, a short course muscle relaxant or opioids as needed. But you have to be very cautious, and you have to use your risk assessment tool when you're using opioids. Tramadol does seem to have a unique structure because it has a dual effect, a weak opioid affinity, but 2/3 of it's actually similar to vanlivixine, which is an antidepressant. So it's an SNRI inhibitor, reuptake inhibition. So it does seem to have a reasonable effect on chronic low back pain with maintaining some functionality.
Dr. Maan?
Can I just
the use of
for a moment? Do you have the facility that's when you talk, it is writing on the screen?
I don't know how to do it.
No, because it is confusing the participant.
Now, is it better now?
Yes, it is now.
Okay.
Thank you.
Okay, I'm almost done anyways. If you want to repeat, I can repeat the, the presentation. Yes. Antidepressants usually that inhibits norepinephrine reuptake, classically tricyclic antidepressant and tetracyclic ones, and SNRIs, as I said. So vanlivixine, duloxetine, amitriptyline, and the group of the tricyclics are actually very commonly used in chronic low back pain because we see commonly depression is an issue with most of these patients. It's not recommended in the acute phase. It's recommended mainly in the chronic phase, especially when the patient does complain with the radiculopathy and neuropathic component. Anticonvulsant is a very commonly used class of drugs. The evidence is actually very limited, specifically for radiculopathy, but it's especially with gabapentinoids, pregabalin and gabapentin. Carbamazepine is a classic example. We use it for trigeminal neuralgia. We try and avoid it, most of us, initially because of the side effect profile. But gabapentinoid has been used and we use it frequently. But again, the evidence is not out there for the efficacy of radiculopathy. So most of the time, I actually lean towards trying that for some time when they have a significant neuropathic pain component, and then give them a break out of it. So try it for few months, probably a month or two, if they have some benefit, and then try and wean them off it and give them some rest and see if they actually doing better without it. Now, again, as Dr. Adil was saying, it's really important to really look for red flags. As soon as you see them, you have to think about some diagnoses, so you can refer to a spine surgeon as soon as possible. So fever, weight loss, intractable pain not improving within 4 to 6 weeks. As we said, most of them, they tend to improve in the first few weeks. Nocturnal pain, increasing pain severity, morning stiffness, especially in the younger than 40 years of age, and neurological deficit, bowel bladder problems. And these are the things that you should be worried about. Herniated disc, spinal stenosis, Kodak Wine syndrome, inflammatory spondylolisthesis, spinal infection, vertebral fracture, cancer, and so on and so forth. So like cancer, abdominal aneurysm, these are actually out of the context, things that you need to refer to do appropriate diagnosis with investigation tailored to that and refer to a specialist. Now, to take home message, to keep it simple, low back is a very common complaint. Most of them tend to resolve within 2 months, 90% of the cases. The key element is stay active. Bed rest is not recommended. Significant exercises at the acute phase is not recommended. So as the limiting factor is pain, but stay active, let them walk, let them move as much as possible, and be aware of red flags. That's it. Thank you.
Thank you, Dr. Mahan. Definitely, we have received a lot of questions for the conservative treatment. And as we said, we will keep all the questions at the end of the sessions. And now we will proceed with the next speaker. Dr. Dina Nabil is a graduate from Cairo University, Faculty of Medicine. And she was a professor of anesthesia and pain management, and intensive care and pain relief in the National Cancer Institute in Cairo, Egypt. And currently, Dr. Dina is working in pain management consultant in Saudi German Hospital. And Dr. Dina will talk about the minimal invasive procedure for low back pain, a bridge before surgery. Isn't it? I have a lot of questions already, Doctor, about management and minimal invasive. Okay, Doctor, please, your talk.
Thank you, Mr. Chairman, and I want to thank Dr. Adil Kamal for his excellent presentation, which made things easy for me. And I want to thank Dr. Mahan Qattan for his very informative and excellent presentation. And I will start my talk about low back pain. As mentioned before, it is the first cause of patient to ask the medical advice. Usually we start with this slide or presentation.
Can you share your slides? Can you tip on the screen so you can put the whole screen, your slides on the whole screen? من تحت التولز.
سلايد مود يا دكتور. شكرا.
سلايد مود.
Okay. Since 1990 until now, still we say low back pain is #1 problem, and it causes many problems in acute and chronic disease, and it causes a global burden on health community. So this should be something wrong, because after all advancement in intervention and in surgery, still back pain is #1. Degenerative changes seen on X-ray don't correlate with the occurrence of pain. If we are studying radiological image in asymptomatic patients, in asymptomatic volunteer, not patient, we will find many radiological evidence without pain. So we can't believe X-ray, including CT and MRI. So what we can do, we have to look carefully in good light, as Dr. Adil said. We have to listen to the patient. We have to examine him thoroughly And at last, we can seek for the X-ray and the radiology. Pain is a physiological symptom. It cannot be photographed, radiographed, or biopsy. So clinical evaluation should be decisive, not imaging. There is recent classification for low back pain. It can be nociceptive or neuropathic or predominant central sensitization. The pain is in the brain. I'll present a case who came to a pain clinic, 46 years male, 70 kilogram, presented to pain clinic on wheelchair with severe pain in left lower limb. The pain, as he's described, it is electric-like, tingling, with burning pain all the time, with peaks during the day. And more at night, the pain increases with movement. The patient is on pregabalin twice daily, and he cannot tolerate physiotherapy. By examination, positive straight leg raising test, and there is hypoesthesia on dermatome L5S1. This is his radiological image. As we see, there is modic changes. As we see, there is disc herniation. What can we do for him? He is referred to do epidural or steroid injection. Which epidural is recommended? Epidural can be done interlaminar, but when we are doing interlaminar epidural, we should predict some failure because the spread to the ventral epidural or to the site of pathology occur in 36% of cases, and the unilateral flow can occur. But when we are doing transforaminal epidural steroid, we are targeting the site of pathology, the site of nerve compression. When we are doing it through the sacral hiatus or caudal epidural, large volume is needed for the block to be effective, and it is away from the site of pathology or from the area of pain generator. So transforaminal injection is better. This is the fluoroscopic view. This is our target, what is called the Scotty dog appearance. This is the superior articular process, transverse process, the pedicle, and this is the subpedicular or transforaminal. This is the whole foramen. And here we can reach the epidural through interlaminar approach. This is the fluoroscopic view of posterior or interlaminar epidural. And this is the target for transforaminal below the pedicle. And this is in the AB view. The depth, of course, with the lateral view. This is the dye spread, it's typical dye spread of L5 transforaminal epidural injection. But is this safe? Usually, this was our approach. It was called safe triangle. Actually, it is safe for the nerve to avoid nerve injury. This is the triangle, our target, which is bounded by the nerve root, and the laterally is a line from between the two pedicles. But many cases reported with paraplegia after transforaminal injection due to what is called injury or spasm of the artery of Adam Quiggs, which is the main supply of the spinal cord, and it is found in the area from T9 to L2 in 85% of cases on the left side in 85 of individuals. Artery of Adam Quiggs is a small radicular artery found subpedicular. So it was mentioned that in a study that 97 of cases showed that the artery of Adam Quiggs was located in the upper half of the foramen, and it is found in 10% in the lower half of the foramen. So there is suggestion to target what is called Camping triangle for transforaminal epidural injection. This is the subpedicular approach, and this is the Camping triangle. Lateral to the superior articular process. Here you can reach the foramen safely. Lateral, this is the fluoroscopic view, lateral to the superior articular process. And this is the AB view, and this is the depth in the lateral view, and this is after dye injection. This is a study for the evidence of epidural steroids in the acute or subacute stage of radicular back pain. The conclusion of this study that the results of clinical trials are heavily influenced by specialty, who is doing the intervention. With those done by intervention pain physician, more likely to yield positive finding. Transforaminal injection are more likely to yield positive results than interlaminar or caudal injections. Randomized studies conducted by spine surgeon in surgically amenable patient for surgery indicate that in some patients with use of transforaminal injection, we may prevent or avoid surgery. Another study for the evidence of and efficacy of epidural injection, the conclusion was that from this systematic review, that the quality of manuscript and outcome parameters shows that the efficacy of epidural injection in managing a magnitude of chronic spinal condition. Predictors of responder to epidural steroid, higher success rate was found in the acute or subacute cases less than 3 months with clear pain generators and no previous back surgery with accurate target of injection and young age. Low success rate when the pain become chronic or long duration of symptoms, or inaccurate diagnosis or prior back surgery, or inaccurate target done by inexperienced hand and in old age. So there is recommendation to do rapid intervention, rapid treatment of back pain before central sensitization occur, before pain become chronic. So early intervention can benefit patients at high risk of developing chronic pain. Many studies are done suggesting that early intervention and the early management of pain prevent pain from being chronic. This algorithm suggestion for management of radicular pain. If the pain is in the acute or subacute stage, transforaminal epidural steroid is recommended. If it becomes chronic, so pulsed radiofrequency is recommended for the dorsal root ganglia. If there is insufficient results, spinal cord stimulation will be suggested, probably for cases of failed back syndrome. The evidence for transforaminal injection to be positive, and for pulsed radiofrequency it is 2C, so they are recommended. In the diagnostic phase, the block can be repeated 1-2 weeks interval, and in the therapeutic phase, it can be repeated up to every 3 months or 4 times is maximum per year. Second case of 22 years old nurse lifted a patient, complained of burning pain, numbness from low back radiating to her right leg and foot. She tried rest and analgesics, but she didn't improve. CT and MRI were normal. Epidural steroid was done, but she didn't improve. There was severe back pain. She was bedridden. The leg was cold, blue, and swollen. So lumbar sympathetic blocks was done for her, and her leg become fine, but her back pain persists, and the symptoms return after 5 days. L4-5 and the L5-S1 facet joint block was done. There was dramatic relief for her symptoms, and the block was repeated after 3 weeks, and her pain improved. So radiofrequency denervation of lumbar facet was done, and the patient relieved completely at her follow-up period up to 12 months, and she returned to work as full-time. X-ray and investigation and the MRI should be interpreted with caution, including CT and the MRI. Facet joint pain, often it is not just the joint only or the dorsal ramus. There can be a component from the ventral ramus or sympathetic supply. So this is the dorsal horn. There is communication from the ventral root, and there is communication from the sympathetic chain through the rami communicans. These interventions are usually missed. When we doing lumbar sympathetic block or the communicating branch, this may relieve the pain because it is not only one generator, it is not only one source of pain. As we mentioned, there is communication between the anterior supply and the sympathetic chain. Also for discogenic pain, when we have back pain without radicular pain, this pain can be visceral, somatic, or mixed pain. This is the disc compressing the nerve root, but again, we have communication from the sympathetic supply and we have communication from the ventral root. So targeting these rami communicants can relieve the patient. Somatic nerve supply is from dorsal spinal nerves. Sympathetic.
Time, Doctor.
Okay.
Time, please.
Okay. Okay. By sinovertebral nerve. So discogenic pain is mediated by sinovertebral nerve. Also, the anterior compartment doesn't play a role alone. There is some affection from the posterior compartment as well. So we have to look carefully in good light for all pain generators. I'll skip a lot of. There is recommendation from the NICE guidelines that radiofrequency should be taken before surgery. And the spinal surgery is recommended for sciatic pain, which doesn't relieve by injection. And no spinal fusion or disc recommended for low back pain. This consensus for practice guidelines for intervention for lumbar facet pain from multi-speciality, not only pain physician, that radiofrequency can be done after diagnostic block and improvement, even if the improvement is 50%. The results of RF depends on selection of the cases and targeting the nerve. This is the nerve. This is a pulse. When we are applying thermal radiofrequency, the lesion is so small. So we have to target the nerve and put the needle at its exact site. This is the lesion. It is ellipse in shape, about 1 to 2 millimeters. So if we are not targeting the nerve, we will miss the efficacy. The lesion can be increased by increasing the gauge of the needle and use of curved needles.
2 minutes, Doctora, please.
Okay, this is our target. When we are putting the needle perpendicular to the nerve, we miss our target. Okay, this is the size for median branch block. The evidence is 1B, and we try to avoid doing the lesion on the ligament. We have to advance the needle on the nerve, not the ligament. Feldbeck syndrome is an important issue. It doesn't mean failed surgery. The surgery can be good, but it means failure in the diagnosis. And actually, it is a syndrome that it can occur, the incidence up to 40% of cases. Caudal neurolysis can benefit such cases by use of Rags catheter, and we do adhesolysis for the fibrosis. And we should look for sacroiliac joint, which usually occur after spinal fusion or fixation. Can be targeted with injection with local and steroid or radiofrequency by use of cooled radiofrequency, better efficacy, or bipolar radiofrequency. Rather
How much
than
time you still have here,
the
Doctora?
last slides. My conclusion: back pain is a dilemma. We should work in a interdisciplinary and multidisciplinary approach. We should try to target all pain generators. Thank you.
Thank you, Doctora.
Thank you.
And thank you for the whole team for this intensive information about the management of the back pain. And I still have a lot of questions, therefore, we would like to start with our discussions. Let's start with Dr. Adil. The first question I have here, Doctor, is from the participants. You have mentioned most of the diagnostic tools, but when the patient comes to your clinic, you must have something like a standard diagnostic methods, tools in making the low back pain diagnosis in this dilemma of information coming from the patients. So what standards you usually do when you have the patient coming in your clinic?
Thank you. This is a very useful, very important question. You're absolutely correct. You have to have a pathway or a technique in order to point yourself towards the most likely diagnosis. Again, careful history and careful physical examination is the key. You can diagnose 99% of the cases by simply doing very careful history and very careful examination. An example, just on Thursday, I had a patient, 75 years old, who was referred to me with a diagnosis of a cervical radiculopathy because the MRI showed C5-6 and C6-7 degenerative changes, significant changes with spinal stenosis and neural foraminal narrowing on the left side. And 3 physicians saw him and they sent him to me. And the narrowing was mostly on the left side. When the patient came with a careful history and examination, the patient was simply complaining of pain behind the right ear and the right side of the neck and the right shoulder. So if you talk about C6-7 and C5-6, the pain should be in the shoulder mostly, not behind the right ear. So with a careful history, we found out that the patient, when he sleeps, he put his hand, the right hand behind his right side of the face, and quite often he pressures and uses one. So we diagnosed him as lesser and greater occipital nerve palsy because he had change in the sensation in the distribution of those two nerves. And when we simply blocked the nerves with the local anesthetic, the pain disappeared right away. So careful history. Where is the pain? We go back to fourth year medical school, location, duration, nature of pain, elevating factor, relieving factors, radiation, associated symptoms. All those are very useful to make us reach the diagnosis. Then the specifics. I do examine the patients, start examining as soon as the patient walks in. I look at his gait. I ask him to stand on the toes, stand on the heels, bend forward, extend backward, and I feel their back, and I would feel where the tenderness is, and that would help me to reach a final diagnosis. If the patient is complaining of numbness going to the foot, then that's, of course, directly points me toward the radiculopathy, and I would go with the more symptoms of the radiculopathy, but I would not neglect the other potential coexisting conditions. I have many patients with both radiculopathy and facet and sacroiliac joint and diabetic neuropathy all in one. So
Yes.
careful history examination is the key.
So all in one, you would do what? All in one.
What I
where
mean,
to
all in one, he had all the causes for it. I would ask the patient, what is the most problematic to you? What's bothering you the most? Low back pain or leg pain? If he says the leg pain, then my choice would be directed. Maybe he would benefit from an epidural steroid injection. But if he mostly complained of low back pain, then facet joint would be possibly the option that I would go with, or the sacroiliac joint. In all honesty, I have a very busy practice. Quite often, I do all of them. I do epidural, sacroiliac, and facet all at the same time. But depending on the number of facet joints that I would have to block, and if both sacroiliac joints are involved, and of course I have to monitor the amount of steroids that I would be using in this patient.
Yes.
All this
That's what
have to be factored in, of course.
That was also my next question to you, but I will go to Dr. Mann, because this will lead what Dr. Adel has said. Leads me to the next question, Dr. Mann, about the word. Sorry, because I have. Did you hear me for my question?
ما سمعتك أيوة لا تاني. Can you repeat it again, please?
كلمة ثانية.
تفضل.
يعني I'm talking about the multidisciplinary teamwork in regards back pain. What we see in the clinical practice, we don't see it actually. We see patients coming to the surgeon. The surgeon has done the surgery. I'm saying just an example. The surgery failed. When I feel desperate and I have no choice and I have no solution for this failed surgery, I've referred him to the pain clinic, or to the physiotherapy, or to the neurologist, or to the psychiatry. But I don't see in practice this word multidisciplinary. So how you manage this word in multidisciplinary team?
That's a very good question. So the model that you're talking about, I've seen it in multiple centers, not necessarily here, as you said. There are certain areas where they actually practice that in one center. It's led by multiple physicians and a complete team of psychologists, psychiatrists, and physiotherapists, rehab, and they have everything in it. We've seen it in certain centers in North America and Europe. In here, I think it's available in certain areas where there are tertiary hospitals. But as you said, absolutely, most of the time it's a single discipline where the patient comes in and then you do your assessment, and it depends on your personal effort and your networking with other physicians to refer them to. So in an ideal practice, such cases should be referred to family physicians or general practitioner. They will do the initial assessment, and then they would send them to an appropriate center where the initial assessment should be done by either a spine surgeon or a pain specialist, where they can actually just go from the phases. Where did they see the simplicity or the complexity of the case? and refer them to stages of the plan of action. And a lot of the times in such centers where they exist, and I've seen it practiced before, they actually do rounds. So they sit on table on daily basis, the surgeon, pain specialist, the psychologist, the rehab, the physical therapist, and they discuss cases that comes to that multidisciplinary center. Unfortunately, as you said, most of the cases here are actually just the access to tertiary care or to spine surgeon or the pain specialist comes in directly, in which a lot of us, by practice, they develop their own skills into diagnosis or looking at red flags or having that experience, I should say. So you are right. Most of the specialties that I've seen, they don't actually deal with it, except in certain few tertiary centers that I see do well. I won't mention names, but there are few that they practice that. And this actually can lead to sometimes what we call the expectation of the patient wouldn't be as he wants. Most of them actually recover well if they go to the appropriate center. But unfortunately, I don't, I've never seen that, at least in our city. You
don't recommend, like we have like the tumor board. You see, in tumors,
that's what I'm saying.
Huh?
That's exactly what they do in the multidisciplinary or interdisciplinary. For instance, there is in McGill in Montreal, they have a neuromodulation unit where they have the surgeon, the spine surgeon, the rehab team, the psychologist, the interventional pain, the whole team sits there on daily basis, and they discuss all the cases that come through the clinic from A to Z, regardless if it's simple or it's very complex. And there is a clear referral system from the GPs or from other centers. This is ideal. Unfortunately, it's not applied in most of our centers here in the region.
Okay. Now I come back to Dr. Dina. You have said in your talk that you should interfere before the patient becomes chronic, which usually does not happen. It does happen when the patients are becoming chronic and they come. You see, the word pain clinic is something new in Saudi Arabia. We know it in Europe and in the States, in North America, but in Saudi Arabia and in the Middle East, this is something, it is new trends. So the patients are not aware of the pain clinic. They come either to the spine surgeon or to the neurosurgeons, to neurologists, to orthopedic surgeon, and they become, most of them become chronic. And when we refer the patient to the pain clinics, we refer them not at the beginning, because we surgeons are arrogant and we think the patient will benefit from the surgery and not from the pain management. But how you see it from your point of view? You said you should refer it to me and I should manage it first before you do the surgery. Is this right?
Yes, it is not my word. It is the recommendation of the IASB, of International Association.
I know it is not your word, but what is in the practice is like this.
Unfortunately, in the practice, this doesn't happen. Rarely this happens. Referral from a surgeon to give the patient chance for minimal invasive intervention before he do surgery. Some surgeons do that, but we need to spread this awareness among patients and among surgeons to do that. And insurance also, we have very big problem. They said to us, this is not the first line of treatment. This is not the standard treatment. So we need to do a lot of effort to spread the awareness regarding that. Because
so
the
IASB
suggests that you should try to prevent pain from becoming chronic, because it is not only mechanical cause of pain. The pain pathway, there is augmentation, so the brain is accustomed that there is pain. So if we interfere lately, the patient may not improve.
Where is the line, Doctor? Where is the line between the word chronic and the word early intervention?
The definition of chronic pain, it is after.
No, not the definition. I mean, I am having a patient. Do I really send the patient from the first visit to you to handle his pain, or because I am a surgeon, my own efforts is directed to the surgery, whether it is indicated or not?
There is some cases there is a sharp indication for surgery if there is motor affection, if there is sphincteric, so no rule for intervention in such cases. But some cases we shouldn't refer him to physiotherapy, and he has pain. He cannot do physiotherapy. So he should be referred first for pain clinic. We may do some intervention to relieve his pain so he can go for physiotherapy and improve. And as Dr. Adel said, that the natural history of for back pain is resolution. So we may avoid unnecessary surgery if we manage cases in such a way.
Thank you. Just another round. I go back to Dr. Adel. Dr. Adel, I have a scenario here in front of me by questions. Patient is coming to you in the clinic, and he give you a vague information about his back pain. He gives back pain, leg pain, arm pain, and so on. How you would differentiate this in your clinic?
Again, your understanding of the patient and the careful history and physical examination again. Coexisting diseases. A patient, with all due respect, I'm not being sexist, but if I have a female patient with a history of irritable bowel syndrome and generalized body pain and pain mostly in the upper back, middle back, low back, hand, legs, goes more with the This is the diagnosis that goes more with the fibromyalgia, which is common in females compared to males with a ratio of 3:1. There is a vague history usually and pain everywhere. So those candidates might not be candidates for nerve blocks, for example, or trigger point injection or something like that, but more of a systemic medication. We usually start with tricyclic antidepressants, gabapentinoids, weak opioids together, some of this or some of that. Physical therapy, those patients can benefit from aqua therapy or exercise in the water or simply walking in the water. You know, it's just your own understanding and feeling and expertise in or gut feeling about the patient. And you try simple approaches first. And of course, you're not going to jump to the big guns first. We start with a simple, routine, usual approach to management of any pain, and then we take it from there. But I do get those patients quite often, either generalized osteoarthritis or fibromyalgia, and presentation is usually the same, but you can differentiate between the two by the location of the pain. Generalized osteoarthritis pain is mostly around the major joints, while fibromyalgia is not related to any joints. So sometimes it's very difficult. It's not very easy to simply reach a diagnosis. But again, careful history and careful examination is always the key to me.
Okay, thank you. Back to Dr. Mann. Doctor, a patient comes to you with a COVID positive, and he's complaining of back pain. طبعا you are taking the whole precautions to handle this patient. But my specific question is how you do today the back pain, because a lot of patients are complaining in this pandemic era of back pain, and it might be a general question, but how you face this?
Excellent question. So this is a very, very excellent question. Such a time where we see the common disease process is getting worse because of the availability of resources and physician attention to them, and the diversion towards COVID. So a lot of times there is a distinction between, first of all, is the patient symptomatic from the COVID? Is it the viral illness that is causing him the acute pain in the low back or not? So we have to clearly see the patient. As soon as we see the COVID, we want to make sure that we are not, let me put it that way, we're not distracted by the diagnosis. So what I want to rule out, I just want to rule out, first of all, if it's related to the viral illness, is the patient becoming symptomatic? Is it the fever causing the common muscle ache and stuff like that? Or it's an actual pain that is not related? And we've seen a lot of plethora of information with whether it's good reports or bad reports about COVID cases. But a lot of times people pay attention that the COVID positive is the whole thing, and they're really not looking at the secondary infection or the secondary disease process. So they can miss diagnosis of cancer, they can miss diagnosis of disc prolapse, and so on and so forth. So this is the key that I've noticed over time. A lot of the thing, because of the panic and the anxiety and the overwhelming reports that comes in and the amplification by the news and social media, people will just focus into COVID positive. Yeah. Likelihood they're asymptomatic from the COVID, and it's just a PCR test. So what I would urge physician is just make sure, as you said, take your precaution, do a thorough physical examination, and then try and distinct, is the COVID related to what's going on or not, and give yourself a timeline. So when you think, when the first few days they don't respond, and it's not related to the disease itself and they're not symptomatic from COVID, then you have to do your usual workup of acute low back pain and go from there. This is something that low back pain probably is the least of them. I've seen, unfortunately, a lot of time-sensitive diagnoses like vascular issues, cancer patients that they're deprived from the appropriate care. Unfortunately, even simple pneumonia and MIs, just because people are afraid to go in and assess the patient, they don't actually get the appropriate care.
Thank you, Doctor. My last question, I have a lot of questions, but the time, I think we have to proceed and to finish on time. Dr. Adina, again, coming back to your chronic problems. I have a patient, as you have said in your, as a case presentations, I have a patient who came to me and he has done, this is a physical, real patient. I have this patient and received, and he's complaining after 7 surgeries in his back, and still his pain is still there. He's complaining of. So how you deal really with chronic patients with failed back surgery, multiple surgery, and we have, I mean, as a senior in the spine, I am seeing nowadays a lot of young surgeons who tends and go directly to the surgery without, as Dr. Adil said, and Dr. Gattan and you, thoroughly examine the patient and see the cause of the pain. So they tend to have multiple surgery with a failed back syndromes, and they come to you in the clinic. I usually don't do these patients revisions unless I am really 100% sure that the diagnosis is correct. Now my questions to you, how you deal with these patients when it comes to back pain, and I refer them to you with a failed back surgery?
Actually, this is a challenging case to a pain physician because usually the patient has multiple pain generators, and he has a psychosocial element added to this. So I'll try to target all these aspects for the patient. After exclusion of red flags, what is called red flags, infection, arachnoiditis, something like that, I can interfere. I'll deal with bony and tissue generated. The patient will have most probably.
Can you repeat because there was intervention? Can you just repeat the last words after the red flags?
I'll deal with such patients will have probably facetal pain, will have sacroiliac joint pain if they, especially if there is patient. He will have radicular pain. So I'll try to target the radicular pain by transforaminal injection or what is called adhesiolisis, direct catheter and the infusion of drugs like hypertonic saline, hyaluronidase, to try to dissolve the fibrosis and adhesion. This can be repeated. I'll target the facet joint, the sacroiliac joint, the muscle. Most probably they have muscle pain. And together with medical, of course, medical drugs will be multimodal, paracetamol, muscle relaxant, gabapentoid. All these can be done to help such patient. We may need psychological support for him. At last, if all these failed, we will try spinal cord stimulation and, for example, drug opioid therapy implant. If we fail, because it is really a challenging condition.
Yeah. Thank you very much. Thank you, all of you. And I really have a lot of questions. Maybe we should have another session to answer only the questions that I have. But at the end, I would like to thank you all, Dr. Adil, Dr. Mann, and Dr. Adina, for your participation in this webinar. And I would like to thank Saudi German Hospital for inviting you and for all the participants, and have a nice evening. Thank you very much. Goodbye.
Thank you very much. Thank you for the invitation.
شكرا جميعا. السلام عليكم.
شكرا لكم. مع السلامة.
السلام.